So you've had enough, have you? Tired of the heartburn, regurgitation, all life interruptions that come from reflux? Well, if so, this guide is for you, my friend. Whether you're a once a week reflux kind of person or you have more advanced reflux, my goal is in this video is to review all the options you have for treatment out there and the pros and cons of each. Sound good? Cool. First, I'll cover the standard lifestyle advice, help you sort the wheat from the chaff as we dive into food triggers, behavioral modifications, herbal remedies. And then next I'll cover the medical treatment options, including medications and surgeries. And then finally I'll outline how you should approach long-term natural resolution by outlining the root causes of acid reflux. So let's first cover the standard advice for acid reflux. This is the run-of-the-mill advice you'll get if you search the internet. Unfortunately, much of this information has been circulated as part of media sensationalism, more to make headlines that grab eyeballs than to actually dispense sound, proven advice or information. The internet can be kind of like a game of telephone, where the message is passed along website to website until the integrity of the message is completely lost. So let's sort out the noise. First of all is food triggers. And if you ask anyone about how to treat acid reflux, I'd lay good money that the first thing out of their mouth is going to be about food triggers. It makes sense since acid reflux is a digestive problem, so it's no surprise that food plays a crucial role. The problem is, research is inconclusive on basically all foods. There's a lot of observational studies with people self-reporting their triggers, but far fewer controlled trials. And when researchers try to run controlled experiments, they tend to come back with very conflicting results. For example, you can find a study that concluded that fatty foods make heartburn worse and onset faster, and then an almost identical study where the fat content made no difference. And so it's not just about fatty foods, it goes for all these common food triggers around reflux. But the bottom line is that I can give a good place to start, but please keep in mind that you'll have to carve out your own dietary solution based on your own individual experience. Now, the fastest way to get you up to speed is my acid reflux food trigger tier list, which I'll bring up on the screen now. It'll help you prioritize food triggers when looking at short-term symptom relief from acid reflux. Now, I base this tier list on a couple of key research papers, which I'll kind of link in the description down below. And those research papers kind of did a meta-analysis, which is a big review of research on diet and GERD. And then I use my own experience in practice to further enhance the resource. And so if you're wondering, why are there no alkaline foods listed, or you just want a deeper explanation of the resource as a whole, you can read my explanation. I'll put it linked in the description as well. But for the purposes of the video, I'll just cover the highlights. Really quickly, let's talk about each of these groups at a high level. Firstly, there's those foods that you should definitely avoid. Those are the fatty, oily, fast foods, and then alcohol and citrus. Now, with those fatty foods, there is some evidence to suggest their role in acid reflux, both in starting reflux and also triggering. It's not the strongest, but there's definitely something going on there with regards to how they affect some of the root mechanisms that happen in the stomach, as well as just being generally unhealthy. So that's why they're in the definitely avoid, because they're just not doing you any good. Alcohol is a known trigger of reflux symptoms. There's of course evidence on both sides, but generally speaking, it's considered a trigger of reflux, but not a risk factor. So long-term use of it isn't what causes, or not at least what appears to cause reflux to start. Citrus, however, does seem to be a risk factor, as well as it's popularly known as a common trigger. So that's why it's also in the definitely avoid category. In the probably avoids, you have carbonated beverages and spicy foods. Now, spicy foods are a tricky thing to pin down. Research kind of broadly specifies them. Sometimes they're just foods that have the capsaicin, that thing that makes things spicy hot. And then sometimes included in the group is things like garlics, leeks, onions. If you think of curry, it's got a ton of spices in it. So that can be the spicy food definition as well. But generally speaking, there's a lot of survey information about people just saying that spicy foods trigger them, as well as some evidence that they might be a risk factor. Carbonated beverages are also a risk factor, maybe not just the carbonation, but because a lot of carbonated beverages just aren't healthy. They're high in sugar or all sorts of other chemicals if you drink energy drinks. So that's why those things are in the probably avoid category. In the maybe avoid, you might be surprised to see caffeine. So coffee, tea, chocolate, these things research shows they actually don't make any clear triggers, or they're not triggering symptoms, which can be kind of surprising because a lot of people cite it as something that's a common trigger for them. And so it might be more along the lines of something like when you eat it, or what you eat it with or consume it with. But research isn't able to draw that conclusion. So it's a maybe avoid. Depends on you. And then mint. The studies I looked at only looked at one paper on mint, which might suggest that it's just not something that's believed to be an actual trigger, although some people do cite it. So that's a maybe avoid. And then there's some definitely adds. Whole fruits, whole vegetables, whole grains, beans and legumes. These are the foods that really promote good digestion, promote good health. And so as you pull some of those things out, add these things in, they're definitely going to help. Now, my main notes here are to focus as much or more on the additions as you do the subtractions. So yes, some of these food triggers make uncomfortable symptoms, and they may even have contributed to your reflux. But if you don't replace what you pull out of your diet, you'll miss out on a lot of the healing and digestion calming effects that diet can have. So focus as much as those additions as you do the subtractions. Now, here's the thing no one tells you about food triggers. Look beyond the black and white of the list. You need to consider, first of all, at what dosage or quantity these foods trigger you. You need to consider in what combinations with other foods they trigger you, and other non-trigger foods at play, so things completely undietary related. In other words, don't just remember what you ate, but how much and with what else you ate it, and what was happening beyond your plate as well. For example, you may find that hot salsa makes your reflux worse, but you can tolerate it as long as you don't have it with a big greasy meal. Or you may also find that a spoonful of salsa is fine, but if you put more than that, you're in for a long night. To make it even more confusing, you'll have to consider non-food factors like stress, meal timing, and other behaviors that can contribute to symptoms and severity. Also keep in mind that the longer that you've had reflux, the more irritated and damaged and inflamed your esophagus is going to be. And so a more sensitive esophagus means a broader range of foods are going to irritate it and potentially cause uncomfortable symptoms. And it's not uncommon to experience reflux even eating all the right things, especially if your reflux is more advanced and or if you are just beginning dietary changes. So the bottom line is it's inherently tricky to get clear on signals on food triggers. However, it pays off to learn the boundaries of your body so you can have more control. If you want some help or get some trained eyes with your situation, you can always get in touch with us at our website. I'll put the link in the description. Behavior modifications. Behavior modifications refer to some of the habits that you can change or implement to help manage symptoms of acid reflux. I group them into two categories that make them easy to remember, at least for me. First of all is pressure, and second of all is gravity. Anything that builds pressure in the abdomen or stomach is going to increase your risk for reflux. You can decrease pressure by wearing looser fitting clothing, eating smaller, more frequent meals, or stop drinking carbonated beverages. Anything that changes the angle of your body is also going to change it so that gravity can no longer assist in keeping that acid in your stomach and will increase the risk for reflux. You can, first of all, not eat within 3 to 4 hours of going to bed, elevate your bed or body during sleep, or don't exercise on a full stomach because that's going to slosh things around. Laying down on an empty stomach and elevating your torso during sleep is going to do the maximum that you can get from that gravity to help create gravity on your side and acid in your stomach where it belongs. The recommendation is backed by research. So there actually is a body of research that shows that this definitely works. So make sure to implement it. If you exercise after you eat, you'll be prone to that extra slosh I was talking about, and therefore more reflux. Now keep in mind, these aren't magic bullets. You can still have a reflux episode while standing as still as a statue, upright, wearing your most spacious pajamas, and eating just a snack. This is because your stomach is a muscle that moves around and sort of chews food during digestion. Making these behavior changes gives you the best environment to minimize symptoms, but it doesn't actually fix the natural barriers that stop reflux. Cool. Natural remedies. There are some non-drug therapies that might help with reflux. While there is research that supports some of these health claims, there isn't much reliable research to confirm their effectiveness specifically for acid reflux. But if it does help you, I'm all for it, and it would be a huge win if one of these replaced a drug or similar therapy. Now, the first one is turmeric, and turmeric, ginger, and flax seeds are all known anti-inflammatories. In turmeric, you have the curcumin. I've actually used turmeric myself, and I think it works for me just as well as any ibuprofen would, without any of the stomach cramping that comes when I take ibuprofen for days at a time for a bump or bruise or some sort of injury I get. So that's one thing you could try. The idea here with these anti-inflammatories is that by bringing global inflammation down, or inflammation down around the esophagus, is going to help healing and reduce symptoms as well. Ginger as well, it has anti-inflammatory properties and is a digestive aid in antiquity. And then flax seeds have those omega-3 fatty acids, which are linked to anti-inflammatory. And the reason I like flax seeds versus other foods that have omega-3s is because that seed is just such a natural, healthy package. And then you have chamomile tea, which is a popular digestive aid in antiquity, has calming properties, or at least it's said to. So you can try that. And then one thing I found is deglycerinated licorice. It's a mouthful, but it's basically licorice with a certain chemical pulled out of it. It's said to increase the mucus coating of the esophageal lining, helping it to resist the irritating effects of stomach acid. And you want to get the deglycerinated version, because if you plan to use it long term, that glycyrrhizin is a compound that I guess has been linked to blood pressure or swelling in the feet if you take too much of it for too long. So definitely go for the deglycerinated version. Cool, let's cover some medical options. This is like the medications and the surgeries that are available for acid reflux. And acid reflux has actually enjoyed a lot of attention from pharmaceutical companies and medical research because it is such a common affliction in the US. So let's review the medications and surgeries available as a treatment for acid reflux. There's 4 main classes of acid reflux medications. As always, consult your doctor on your unique situation. I don't know your situation. I don't know you. So, this is just for educational purposes. It's not a recommendation of any sort, nor is anything in this video, by the way, while we're at it. First of all are some antacids. These are the over-the-counter pills that you can take to quickly reduce acid reflux symptoms, and they work because they're chemical buffers that counteract the stomach acid to make it less potent or damaging to the esophagus. Some common brand names are Alka-Seltzer or Tums or Rolaids, and I'd say these are generally a pretty good line of defense with little downside in the short term, as long as you're taking them for, say, like shorter than 4 to 8 weeks. And as long as, of course, you're using according to the directions on the bottle. You might even consider them somewhat natural because bicarbonates, which is the active ingredient, for instance, in Tums, are just already a naturally occurring component of saliva. And the chemical reactions, therefore, that they undergo in the stomach are things your stomach is used to. Of course, it's at much different quantities, but it's little more than electrolytes, water, and carbon dioxide that it's going to create in your stomach. So that's a plus side. There are medicines that use these chemical buffers alongside other active ingredients, namely alginates. I think these are made from seaweed, but don't quote me on that. But alginates, in combination with specific antacids in the stomach and of course the acid in the stomach, form a buoyant raft on top of your stomach contents. And that raft is going to form a protective barrier between the acid and the esophagus. And some brand names you might recognize are Gaviscon, Mylanta. The addition of these alginates brings little by the way of side effects. Usually the side effects people experience are digestion-related, like constipation or diarrhea, actually due to the more specific antacid compounds containing magnesium or aluminum. But long-term effects such as poor nutrient absorption remain. I think we'll talk about that a little bit later when we get to PPIs. Finally, while not true antacids, some medicines work as coating agents. They work primarily by coating stomach ulcers or other damage in the digestive tract in a protective layer to block further damage or inflammation from stomach juices. Active ingredients include sucralfate. I'll put it in writing so you guys can read it, get around my poor pronunciation, or bismuth subsalicylate. Brand names you might recognize are Pepto-Bismol, Carafate, which is available only by prescription. While they come in a relatively small chance of side effects, they do have the benefit of potentially giving your esophagus tissues a break and heal. Now, the next category is H2 blockers. And these are kind of the old generation prescription acid reflux meds, although they're still plenty useful for today. Available over the counter in smaller doses, they work by reducing acid production in the stomach. Brand names include Axid, Pepcid, Tagamet, and then you have the next category, which is proton pump inhibitors, PPIs. And those are the newer generations of meds for acid reflux. Some are available over the counter, but some are prescription strength and available from your doctor. PPIs also work by reducing acid production in the stomach, though they accomplish this through a different pathway than H2 blockers. And brand names include Prilosec, Nexium, Protonix, although there's a whole bunch of them. For short-term periodic symptom relief, these drugs are very effective. The main downside to these meds comes from the chronic long-term use. Weaker stomach acids, first of all, may make it harder for your body to break down and absorb essential nutrients like calcium, folic acid, B12, and more. Long-term use has also been associated with increased bone fracture and potentially due to poorer nutrient absorption. There's also a documented rebound effect when stopping some of these meds after prolonged use because your body kind of adjusts to that acid suppression. And so it makes it kind of difficult to get off the meds if you've been on them for a while. It also may reduce the natural germ-killing properties of your stomach acid, which has been associated with increased C. diff infections and small intestine bacterial overgrowth, or SIBO. So basically, there are costs to tampering with that acid production and acid mechanism in your stomach. So for me, if I was using them longer than 4 to 8 weeks, I'd consider a discussion with my doctor. Please use your own judgment in your case. The next category is PCABs, potassium competitive acid blockers. And so these are newer drugs that use a different mechanism for acid suppression. One is approved by the FDA for use in the United States. Its brand name is Voquezna. I'm probably pronouncing that wrong. And it can be used or prescribed by a doctor if the first line acid suppressors that we just talked about have been ineffective. Studies mildly suggest that they may be slightly more effective than PPIs at treating GERD symptoms, but this is a class of meds that currently come at a pretty heavy price tag. And so a lot of the thinking around it is let's really make the use out of the first line ones before we incorporate this one. And then the last category is prokinetics. And instead of focusing on acid, which all the other meds so far have done, prokinetics help by addressing the reflux side of the equation. So where most meds have focused on the acid of acid reflux, prokinetics focus on the reflux of acid reflux. They work by stimulating nerves in your esophagus and stomach to increase contractions, which moves food down faster and makes lower esophageal sphincter stronger. They can also accelerate gastric emptying so that there's less time the stomach contents can reflux into the esophagus. Now, the upside of this is that they attempt to target more of the root causes of reflux, such as LES function, esophageal clearance, and stomach motility. But the downside is that these are very powerful substances. One has already been removed from the market for causing serious heart issues. It's called cisapride. That was removed a long time ago. And there's another that carries like a black box warning, according to the FDA. It's called metoclopramide, for causing a lot of central nervous system issues, including tardive dyskinesia, which is a condition where you lose conscious control of some of your muscles. Sometimes people start lip smacking without control. And then the problem is when people stop these meds, it doesn't necessarily mean that the problems go away. They actually persist. So it's kind of scary. And for those reasons, the FDA looks at them with a lot of skepticism, and no surprise there. And there are a few available in the U.S., whether due to recalls or simply not applying to the FDA approval to enter the U.S. market. So I've only just listed the ones, or I'll only list the ones that are still available. Also, because they're kind of used for all sorts of digestive tract things, a lot of the acid reflux applications are considered off use for these drugs. So it'd be a very specific circumstance where you would potentially try these, because they're more designed for motility issues in like the lower guts in some cases, and haven't been proven to help acid reflux more than the first line medications. So some of the names of the FDA approved ones include baclofen, and baclofen's actually a muscle relaxer, technically. It's usually prescribed for things like multiple sclerosis and spinal cord injuries, and in acid reflux, it can reduce the transient lower esophageal sphincter relaxations. Basically, your sphincter relaxes all the time naturally, and the more it happens, they link it with more acid reflux. So it can calm those down, and it can also accelerate gastric emptying. So it empties your stomach, so your food stays in your stomach for less time. It's prescribed for reflux when PPIs alone are ineffective, and it has a really high, based on the research I saw, it seems to have a relatively high incidence of adverse effects, maybe as high as 65% of people on therapeutic doses, and long-term use proves fairly ineffective. And also, if you come off it too quickly, you can cause seizures. I didn't have information on how often that happens, but it's one of those things that you should come off slowly. So it's got some definitely drawbacks. And again, it'd be one of those, you only use it in a very specific situation, probably alongside other PPIs, or PPI meds, rather. There's another one called bethanical. It's a cholinergic agonist that increases contractile force. And so it's been shown to increase the pressure of the LES and that sphincter that separates the stomach from the esophagus. Though research is still unclear on if it actually increases healing better than any conventional antacid therapy. So again, these things are kind of off-label uses, and they're not really proven to be better than the other meds. You also have erythromycin, which is actually an antibiotic, and so it's typically used to kill bacteria, but erythromycin is also a motilin receptor agonist, so it sometimes finds an off-label use as a prokinetic agent to treat conditions like gastroparesis, which makes it theoretically good for acid reflux. Its prokinetic effects may help reduce symptoms of acid reflux, though one can imagine the side effects of the gut issues you would get from the antibiotic portion of the med. So keep that in mind. You also have prucalopride. It's a serotonin agonist that stimulates intestinal contractions. It is approved by the FDA for chronic constipation that arises spontaneously. So application to acid reflux is, again, an off-label use. But when 4 women who also had GERD took this medication to improve constipation, they saw their GERD actually go away, according to one paper or one study. Evidence has shown as to how this medication can help GERD is still in development. So keep that in mind, but it has shown promise as potentially GERD. You may not know this, but constipation and GERD have a lot of overlap as diseases. So resolving one might help the other. Now, with those meds, because of their powerful ability to alter key neurotransmitters in the body, prokinetics are reserved for when that first-line acid suppression fails, or to be used in combination with acid suppression. Now, briefly, let's cover the medicines that you shouldn't be taking when acid reflux, or you should definitely limit the use of. And that includes non-steroidal anti-inflammatory drugs, or NSAIDs. Those are like ibuprofens and aspirin. Of course, if you use any of the above meds, you should also make sure that you are not having any interactions with your current medications. And so there's a ton of medications that can cause or worsen acid reflux. You can find a full list of reflux causing meds by using the links in the description below. I'm not going to list them all out here because it would literally take forever, and this video is already going to be a while. But if you are taking something on that list, it could be causing or contributing to your acid reflux. Cool, let's cover some surgeries. The main surgery for acid reflux is called fundoplication. And it's the primary surgery done in severe reflux cases. The procedure basically wraps the stomach around the esophagus to reinforce the sphincter there. Now, you may get a different version of the surgery depending on your case, For instance, there's the kind of standard, I'm going to call it, the Nissen fundoplication is preferred in standard cases where you have a normal esophageal motility, so your esophagus works just fine, because it's a 360-degree reinforcement. There's also some other ones like the toupee or door fundoplication that are preferred when you have weaker esophageal motility. And so if your esophagus is weaker at pushing food through, doing the 360 could make swallowing too difficult. And so there's other versions that wrap to 70 degrees or 180 degrees to support the stomach valve to kind of balance out so the esophagus can still work. These surgeries can be done through open surgery, but more recently, they use laparoscopically or even through the chest cavity. And in the case of the Nissen fundoplication, there's a lot of pros and cons. So let's cover those. There's, first of all, low risk of death, less than 1% 30-day mortality, which is really good for surgery. High long-term patient satisfaction. 80% plus people are satisfied that they did the procedure in follow-up studies, even 10 years after the procedure, which I think is pretty good. Some studies have also documented complete remission of heartburn and regurgitation in the majority of cases, like 58%, though there's unclear, it's unclear what role continued medication use plays in those results. The cons are about 15% of people need another surgery, either due to failure of the surgery to hold or revision needed, such as like the initial wrap was too tight. And that's, I think that was within a year. Around half of people end up back on PPI meds in long term, talking about like 4.5 years and up. And about 18% have new onset diarrhea, with maybe 86% of them having no resolution after 2 years. So, it does change things in the digestive system for some people, which might be a give and take situation, right? You might be willing to take that if you can get rid of your reflux. There's also sometimes an inability to burp or vent gas from the stomach, which means increased flatulence, which somewhere between 12 to 88% of people experience. I didn't find that super helpful, but some people do experience that, as well as bloating, though the majority of bloating resolves in the first year. And then maybe as many as 3 to 24% will have difficulty swallowing that persists beyond 3 months and requires additional intervention. So that additional intervention, usually they stick something down your throat and inflate a balloon to kind of open that stuff up, which often helps. Now, while the Nissen fundoplication is the most common, it's the full wrap to reinforce the valve. It's been a standard procedure for a long time in chronic cases of reflux where meds do not control the heartburn. Because it's been around for a while, there's a decent body of research on the short and long-term outcomes of the surgery. And so the good news is that the vast majority of people who have the surgery done are happy with the results, like we talked about. But there's also a lot of recurrent symptoms that aren't often talked about. So we cover those. The next big surgery is the transoral incisionus fundoplication. Now, this is a newer procedure where the surgeon actually reinforces the stomach valve without cutting you open. They actually stick stuff down your throat, and that's how they're able to do the operation with cameras and new tools and stuff. And they actually rebuild the valve that way by pulling your esophagus down and then folding it over in the stomach and then clipping it. And then a piece of plastic stays in the body to kind of hold that change in place. Now, there's pros. It's less invasive than open fundoplication or laparoscopic fundoplication surgery, which is a huge plus. There's a high technical success rate and almost identical effectiveness to traditional fundoplication, according to current research. Now, the cons are that the improvements are lost over time, and the long-term effectiveness is unclear, again, because it hasn't been around as long as the traditional fundoplications. Post-procedure care requires several weeks of significant diet modification to allow healing. And then not everyone qualifies because transoral incisionless fundoplication is only suitable for a portion of cases. So that's a huge drawback as well. Studies show a successful procedure in 99% of patients, with just 2%-ish, and obviously there's some rounding going on there, experiencing issues during or after the procedure, such as a tear or internal bleeding. Now, some studies have shown 80% of people are able to get off PPIs at 6 month follow-ups. So that's pretty good. But then a study that showed long-term 22% of cases needed to convert to a standard fundoplication. Another study showed 61% of people were able to completely discontinue PPIs at 6 months. But that percentage dropped to 30% by 6 years. So while there's more research is needed, the long-term efficacy appears to be somewhat equivalent to the conventional Nissen fundoplication, but being less invasive. So it could be an improvement. However, of course, like we said, not all people will qualify for it. The criteria usually is a hiatal hernia of greater than 2 centimeters, like 3 to 2 centimeters, will disqualify you. A BMI of greater than 35, or previous endoscopic interventions. Now, the third big surgery I found is called the Lynx. And basically they have this Lynx device, which is a ring of magnets connected by a titanium wire they install to act like your stomach valve. These magnets are strong enough to close the esophagus and prevent reflux, but weak enough to allow food and liquid to pass through under normal swallowing conditions. In many ways, it's an improvement over fundoplication because it's a shorter procedure and it doesn't require a special meal plan as the stomach heals because the stomach doesn't undergo any actual change, which is pretty cool. Lynx isn't without limitations, though. Of course, you're on a candidate if you have a hiatal hernia greater than 3 centimeters. Additionally, if you don't have good esophageal strength, then pushing food past the device could be compromised. Of course, you have the usual surgery risks of infection, bleeding, injury, and surrounding organs, adverse reactions to anesthesia, death, that sort of thing, just like you would any surgery, by the way. But having the device in your body, with the intention that it stays for life, by the way, does carry risks too. So you have to consider a couple things. With those magnets that hold the device together and make it have the proper tension to close, you can't really do an MRI the same way. You have to actually be careful about it because stepping into a big electromagnet can cause serious harm with those devices implanted. They are safe. At least the newer devices, Lynx devices, are safe for 1.5 Tesla scans. Complications could require surgery to take the device out of your body. And then if you have other implants like a pacemaker, Lynx hasn't been evaluated for safety alongside such implements, so consider that as well. Now, according to FDA's summary of safety and effectiveness data on Lynx devices, there was a clinical study of 100 people, and 86 in the 100 of the clinical trial reported a greater than or equal to 50% reduction in daily PPI usage at the 2-year mark, which is pretty dang good if you ask me. 76 had adverse effects, 10 had severe effects. Most of the issues came from difficulty swallowing, most of which resolved without consequence, which is pretty good. Although with that, issues, 18 people needed esophageal dilation for dysphagia. So like 18 people needed that procedure where they stick a tube down your throat and inflate it to dilate your esophagus because they couldn't swallow very well, as well as a few other issues. 12 needed at least 2 dilations, 10 continued to have symptoms. And then in the end, 5 out of 100 had the device removed. So in short, you're likely to experience at least mild discomfort at some point within the first 90 days of getting the device implanted. There's also close to a 1 in 5 chance that you'll have enough trouble swallowing or issues or complications that you'll undergo esophageal dilation. We can also roughly say that there's at least a 5% chance that you'll have to reverse the treatment, either due to intolerable issues or complications from it. So that's the Lynx device. Cool. Let's talk about a natural approach for long-term resolution of acid reflux. Now, doctors and researchers make one crucial error when it comes to health issues in general, if you ask me. They get too wrapped up in the medical solutions that they can't see the big picture. Okay, maybe it's not an error per se, but in my experience, they definitely lean way into the pills and procedures when there's often an easier, safer, and more elegant solution glaring us right in the face. At the risk of sounding a little off my rocker, sometimes the best answer isn't a chemical or some sort of surgical intervention, but rather a change that comes from within. For those that prefer changing themselves and the way they approach life to a lifetime of meds and body-altering surgeries, I'm pleased to say that there's a path for you. Now, it starts with addressing the root causes of acid reflux. And if you were to Google what is the root cause of acid reflux, it's going to tell you that it's a malfunction in the lower esophageal sphincter, like we talked about before, the LES. It's wrong. I know, who am I to challenge the almighty and all-knowing internet and literally every research journal out there? But think about it for long enough, and the same question is going to pop into your head as it did mine. First of all, why? Why does the LES malfunction? Maybe I'm just that kid that asks a million times just to be annoying, why? But if we can answer that question, then we'll have a roadmap to actually fix the root causes and get back to normal living. In other words, we can solve the things that created the acid reflux in the first place. As it turns out, the leading factors to acid reflux disease are really well-charted territory. So I'm going to call these factors predictors as they precede acid reflux and set us up for LES failure. They fall into two broad categories. The first is things that build pressure in the abdomen and then strain the sphincter over time. And second, there's the things that neurologically disrupt the sphincter's function. So this isn't going to be an exhaustive list, but rather a collection of predictors that you have control over. The first one is weight. People who are overweight may be twice as likely to have GERD compared to the general population, according to research I saw. One explanation is that extra weight means more pressure in the abdomen, and over time that wears out the protective valve. It also makes herniation of the diaphragm more likely, changing the anatomy at the junction to promote reflux. Additionally, fatty tissue, especially visceral fat tissue, is also known to throw hormones out of whack and increase low-grade inflammation, which may destroy the mucus lining that protects the esophagus from acid damage. So again, these aren't like causal, like we know, but we know that they're leading factors. Now, whatever the exact mechanism, the answer is clear. Healthy weight loss is one of the best things you can do for GERD. In fact, I found a study that followed 300 men and women with chronic acid reflux through a 6-month weight loss program, and the group lost an average of about 4.75 pounds per month, so about maybe 5 pounds per month, with a goal of 10% body weight loss overall. And the results were symptom improvement in 81% of them and complete resolution of acid reflux symptoms in 65%. Additionally, the researchers found that more weight lost meant less reflux symptoms, which is pretty cool to see. While they didn't measure medicine usage, these results are pretty comparable to the surgery results that we already talked about, without the price tag risks or post-operation trade-offs that one might have to live with for life. Predictor number 2, gut health. If these predictors were road signs, gut health would be an obnoxiously bright electronic billboard with flashing arrows saying acid reflux ahead. The link between generally poor gut health and acid reflux is undeniable. Researchers have found considerable overlap between GERD and other GI issues to varying degrees. And at least one study has linked reflux symptoms to bad bacteria living in the gut. While this connection is pretty well established, the mechanisms and causal relationship aren't yet crystal clear. One possibility is that other gut issues like constipation or bloating can contribute to pressure in the abdomen. Another angle is that having a colony of bad bacteria in your intestines also increases low-grade inflammation, which may disrupt the sphincter function or worsen symptoms, or reduce the protective lining, like we learned earlier. Even the gut's deep integration with your emotional well-being can play a role in the proper function of the smooth muscle contractions in your esophagus, sphincter, stomach, causing acid reflux symptoms. So that's like the gut-brain axis connection. The important thing is that we take our general digestive health very seriously. Nourishing a healthy gut can reduce pressure buildups and improve motility through the esophagus and the stomach, both of which could help with reflux. Predictor number 3, other diseases. Certain diseases in particular increase the chance of reflux. Asthma is a big offender here, potentially because the increased strain while breathing or chronic coughing may change the pressure gradient between the chest and the abdomen, or the medicines taken to manage asthma may weaken the sphincter as well. A vicious cycle can form where asthma, coughing, and wheezing stimulates reflux, which irritates the lungs and airways, which brings on more coughing in a self-perpetuating loop. Reflux also has been known as a major cause of acid symptoms, so it goes the other way too. Diabetes is also an independent cause of many GI issues, including acid reflux. The belief is that high blood sugars damage the nerves and the smooth muscles that operate the sphincter, esophagus, and stomach, which leads to reflux. Proper management of these issues is crucial for control of acid reflux symptoms. And then the fourth is the sin tax, so to speak, alcohol and tobacco. I'm sure it's no surprise alcohol and smoking aren't your friends when it comes to reflux. Most studies have shown a positive relationship between smoking and GERD, so that's very well established. Smoking may affect the body in a multitude of ways, from relaxing the sphincter, chemical changes in saliva, reducing the buffering capacity of saliva, abrupt changes in abdominal pressure, reduced esophageal clearance, all those things. So it's pretty clear that smoking triggers symptoms and also negatively affects other measurable factors in reflux, like esophagus pH and LES pressure. Multiple studies have found like 24-hour cessation of smoking showed no significant change in reflux. However, there are studies where participants succeeded in quitting for a year, and those showed significant improvement in reflux symptoms in 46% of participants, at least in one study, though there were some significant limitations to the study. Alcohol is also thought of as a trigger to reflux symptoms, but it's not necessarily a likely risk factor in developing GERD. Experts have noted alcohol's various negative effects, such as its noxious effect on the esophageal mucosa, which predisposes to acidic injury. Alcohol is also well known to negatively impact the gut in a variety of ways. So while it's not, a direct risk factor, we know it's generally bad for digestion, and given that we know digestion is a big risk factor in developing GERD and root cause, it's probably something you should back off of. Colloquially, it's also known as a contributor to weight gain. So removing it can only help your reflux and can improve reflux through overall better health. So what does this all mean you should do? All in all, while diet research sometimes tells a contradictory tale, it does seem to subtly point to a broader conclusion. The answer isn't black and white on any individual food, but rather to take a bigger picture view on general dietary habits. In other words, you need to be thinking about lifestyle change, not just chips, hacks, teas, single food modifications, and the like. I hope this video on acid reflux treatments was useful for you. If you're considering some guidance to create a more structured plan for your acid reflux, we have a full course on how to master reflux that I'll make available. And then you can also sign up for our online community or app to get access to all of our courses, as well as monthly live workshops. That's all we have for you today. If you liked the video, make sure to like and subscribe, and then we'll see you in the next one.